Cool. So you should be able to see that now. Good. All right. Well, welcome everyone. Great to be here tonight. Thanks for taking the time to be here on a Wednesday evening. I'm going to go a little bit fast because I've been tasked with doing a lot of things in a relatively short period of time. So this will be a little bit of a whirlwind. If I skip over something that you're interested in, we should have plenty of time to discuss things in more detail afterwards. But what I wanted to do is give you a flavor for the life of a clinician scientist in ophthalmology. And I've been asked to talk a little bit about my journey here and then what I do on a daily basis clinically and scientifically, and then a little bit about our screening program as well. So these are my objectives. I'm going to tell you a little bit about how I got to do what I'm doing today. And then really, I want to convince you all that not only ophthalmology is a fantastic specialty, but glaucoma in particular is a really cool subspecialty. You have a huge impact on patients' quality of life. And I had to throw this in here because my 6-year-old daughter is obsessed with The Little Mermaid right now. So we do have gadgets and gizmos aplenty and who's its and what's its galore to play with. So if you're into technology, it's a really fun specialty. I'm going to tell you a little bit about the work that we do in our translational research laboratory to give you an idea of how you can make an impact both by seeing patients, but also doing research that might inform other therapies that we'll be using in the future. And then I'll tell you a little bit about how you can make an impact as an ophthalmologist in community service. So very briefly, my journey was a little bit circuitous. I grew up interested in medicine-ish because my father was a veterinarian. So I helped him take care of cats and dogs on weekends, and then got interested in human medicine, working at a local hospital outside Chicago. I went to Northwestern University outside Chicago for undergrad. That's where I met my wife. And then afterwards, actually took a year off because I wasn't quite ready to apply to medical school. And so I did a year of research in Omaha, Nebraska. I actually lived on a 40-acre horse farm and earned my keep by mucking horse manure and driving tractors on the horse farm on the nights and weekends. And then during the day, I worked with a really preeminent ophthalmologist named Carl Cameras. And as I go through my journey, I want to focus not really on myself or what I did, but really the take-home message for you guys is the importance of mentorship on your journeys through training and your early careers. So each of the places that I went, I was fortunate to have a really outstanding mentor that taught me something really important or really made an impact on the career that I have today. So Carl Cameras, he is sadly deceased now, but when he was an undergraduate at Yale, was doing some experiments where he was tagging epinephrine beads and injecting them into rabbit eyes in order to try to figure out if we could make a sustained release glaucoma medicine based on epinephrine. And he had this weird observation that even in the control group of animals that had beads that had no drug tagged onto them, he was seeing reduction of the eye pressure in those control animals, and eventually figured out that it was a low-grade inflammatory response in the eye that was causing this, and developed, against everyone in the field's feelings whether it would work or not, developed prostaglandin analogs as what is now the #1 medical treatment for glaucoma. So, you know, even before starting medical school, made a seminal observation that changes the way everyone in the world practices ophthalmology today. After this year, I went across the pond and got my PhD at the University of Cambridge. My mentor here was Keith Martin, who is a clinician scientist. He practices glaucoma, and he also does work in neuroprotection. Taught me a lot about how to balance those two things, how to be a fantastic clinician and take good care of patients while also doing really innovative, groundbreaking research that is not so much about the way we practice now or answering clinical questions about how we're treating patients today, but laying the groundwork for revolutionary treatments that are going to come down the road in like 10 years. So, work that he did, he was actually a fellow at the Wilmer Eye Institute in the early 2000s and studied gene therapy for glaucoma. Now has a company that is starting clinical trials and might actually provide the first gene therapy for glaucoma. So again, it's sort of a long range game here, the research that we do, but really has the translational potential to change the way we practice medicine. I did my PhD as part of a joint program between the NIH and Cambridge. And so I spent 2 years in the laboratory of Slava Tomarev, who is not a clinician, but is a PhD molecular biologist, learning really high impact basic science from him. And then I came to Hopkins in 2010, and I've been here ever since. I did medical school, internship, residency, fellowship, chief residency, and I've been faculty for a few years. And here, I was really fortunate to get to know over the years Harry Quigley and Don Zach, who are both glaucoma specialists and scientists who have their own laboratories. And both of these guys really were incredibly inviting for me, welcomed me into their lab and gave me the resources I needed to be doing experiments while I was a medical student and while I was a resident. And then, have given me the push to start my own independent laboratory and start my career on my own. So I think that the key message from my journey has been that I would recommend everyone seek out and cultivate relationships with mentors, and mentors in all aspects of life, not just in the clinical realm, not just in the research realm, but how to do work-life balance and how to teach effectively, how to be a good mentor yourself. I think that's probably the most important thing that can help you achieve success in the future. This is a little bit beyond your stages of training, but if you're thinking ahead towards what happens after residency and fellowship, besides mentors, the next most important thing is to make sure that you secure resources and support in order to pursue the scientific questions that interest you and not get too bogged down in seeing patients 5 days a week. Because the truth is, especially when you're starting your career, a research career requires 3 to 4 days a week to really lay the groundwork and get things moving. And once you've established yourself, it's practical to maybe do a 50-50 split. But in the beginning, having protected time to develop your ideas and get preliminary data and do experiments is critical. And there's a number of funding agencies that provide clinician scientists training grants and career development awards. And so at some point, if this is a career path that interests you, this is something you'll want to think about. So now to talk a little bit about my subspecialty. So what is glaucoma? Well, I'll describe the disease to you first. It's the world's most common optic neuropathy. And an optic neuropathy is just a disease that affects and causes neurodegeneration of the optic nerve, cranial nerve 2, which carries visual information from the eye to the brain. As you probably remember, there are several different types of neurons in the retina. But in my opinion, the most important type is the retinoganglion cell. This is the projection cell of the neuron that carries visual information from the eye to the brain through an axon that traverses the optic nerve. And there are lots of different types of optic neuropathies. You can have ischemic optic neuropathy, like a stroke in the nerve. There's inflammatory optic neuropathy, optic neuritis, traumatic optic neuropathy, toxic optic neuropathy. A lot of things can kill retinoganglion cells. But glaucoma is a little bit unique in that the insult is related to intraocular pressure in the eye. We used to think that that meant you had to have a very high intraocular pressure, like above 20, in order to get glaucoma. We now know that half of people with glaucoma never have a pressure above 20 and really have a pressure in the quote unquote normal range, but just have eyeballs that are more susceptible to a pressure that would be fine for most people. When you get glaucoma, it causes a very characteristic change in the appearance of the optic nerve. This is a normal optic nerve on the left. And on the right, on this two-dimensional picture, it looks like it's just gotten a little bit white. But if you look closely, there's actually this orange tissue here in the left healthy nerve is the neuroretinal rim. This is made of this stuff here, these healthy retinal ganglion cell axons that are taking a turn and going 90 degrees out the back of your screen. And in glaucoma, you lose those retinal ganglion cell axons, and that causes cupping or excavation of the optic nerve head, and you lose this healthy neuroretinal rim. The other important thing to know about glaucoma and all optic neuropathies is that the retinal ganglion cells are part of the central nervous system. So when they die, they're gone forever. And when people lose vision from glaucoma, that's permanent vision loss. At this point in time, we have no way of reversing vision loss from glaucoma, but we can slow it down by making the eye pressure lower. And I'll talk to you about that in a few slides. Clinically, we have a lot of really interesting and fairly accurate ways of monitoring somebody's glaucoma. This is an OCT, or optical coherence tomography, where a laser is used to create an optical cross-section of the retina. And you can do that in the macula. Retina specialists do this to look for things like diabetic macular edema, for instance, or drusen and subretinal fluid associated with AMD. But if you specifically look in the retina at this area around the optic nerve called the peripapillary region, you can create these cross sections and then actually measure the thickness of the retinal nerve fiber layer around the optic nerve. And the retinal nerve fiber layer is what contains all of those retinal ganglion cell axons. So you can create a heat map like this, where you can see these nerve bundles that are coming out of the optic nerve. And this, it looks relatively healthy. The computer is saying that over here, there might be a little area where the patient has a thinner retinal nerve fiber layer than would be expected for someone their age. But we can get this multiple times and actually be alerted to progressive loss of retinal ganglion cell axons if we see specific areas of this thinning within an individual patient over time. So that's the structural way that we assess glaucoma. We also have a functional test. As you probably have heard before, glaucoma, at least in the early stages, primarily affects the peripheral vision. And so we test that using this, which is an automated visual field test. This is the printout that the doctor sees, but essentially, in order to get this, the patient will put their head in a machine and stare straight ahead at a target. And then the machine will flash lights in their peripheral vision at all different locations. And if a patient sees the light, they're going to click a button on the machine. And if they don't see the light, they won't click the button. And the machine will know that they missed that point. And then they'll go back later and test that same point with a brighter light. And they'll keep doing that brighter and brighter and brighter until the patient sees it. And then it plots a map of where the light needed to be especially bright in order for the patient to pick it up. So this is essentially a contrast sensitivity test of your peripheral vision. And on the left here is a patient that has just a little bit of peripheral loss in the inferonasal quadrant from mild glaucoma. This is a patient with moderate glaucoma, where now it's affecting both the superior and the inferior hemifields. And this is a patient with severe glaucoma, where they've lost most of their peripheral vision and have only sort of tunnel vision remaining. This person may still have 20/20 vision on the eye chart and be able to read, but they probably would not be very safe to drive a car if their other eye looked like this as well, because they've lost a tremendous amount of their peripheral vision. Now, we treat glaucoma using 3 different main modalities. We have medicines, and that's shown here. Primarily, we use eye drops, and there's 6 or 7 different classes of eye drops that we can use alone or in combination. We have pills, Diamox, acetazolamide, and also methazolamide, are carbonic anhydrase inhibitor diuretics that lower the eye pressure, but because they're pills, they can cause a lot of side effects, make people feel not so good. There's even versions of medicines that are packaged inside of a slow release capsule that can be injected into the eyeball in clinic. And then that pellet, which you see right here, will actually sit in the eye and release medicine for months at a time to help keep the patient's pressures low. And in the vast majority of patients, I would say medicines are all we need to keep their eye pressure low enough so that they don't lose a significant amount of vision over the course of their lifetime. But I did promise gadgets and gizmos, and so here are some of those things here. We have lasers that we use. There's, probably about 12 or 13 different types of lasers that are used in ophthalmology, and a couple of those are specific to glaucoma. This is a laser called selective laser trabeculoplasty, where you're using a laser to stimulate the cells within the trabecular meshwork. We're looking here at a view of the eye using what's called gonioscopy. And that's because we're looking at this tissue in the anterior chamber angle, which lies right between the cornea and the iris. And you can't actually see this tissue by looking at it directly. Even if you had the patient look way off to the side and then you moved your chair way to the other side and tried to look in there, the light that's coming from this area undergoes total internal reflection at the cornea. And so the only way to see this is to put a lens on the surface of the eye that uses a mirror to reflect that light so that you can see it. And when you do that, this is what the anterior chamber angle looks like at the slit lamp with gonioscopy. And by shining this laser at the trabecular meshwork, you can stimulate the cells to begin to probably clean up their extracellular matrix, become a little bit more phagocytic, and this ends up leading to greater drainage of aqueous humor from the eye and lower intraocular pressure. You may have heard that there's different subtypes of glaucoma. The major subdivision is open angle glaucoma and angle closure glaucoma. So open angle glaucoma is depicted here on the left, where you have aqueous humor that's being produced by the ciliary body. It flows in this little channel between the iris and the lens through the pupil, gets into the anterior chamber, and then is drained through the trabecular meshwork. And when the pressure is high in this case, it's usually because the trabecular meshwork is not functioning optimally. It's kind of like you have a bathtub and the faucet's on and the drain is clogged up with hair or something. And so the bathtub's overflowing, although in an eyeball, you just get a high pressure. Angle closure is a little bit different. In this case, you actually have contact between the iris and the lens. So the aqueous humor that's produced by the ciliary body cannot get through the pupil. And so pressure builds up behind the iris. It pushes the iris forward, which then covers up the trabecular meshwork, and you don't even have access to the drain anymore. So the treatment for this is very different than in open angle glaucoma, where we use medicines and laser trabeculoplasty. For angle closure, we actually use a laser to poke a hole in the iris. So you can imagine that if we made a new hole right here, then all of this built up aqueous humor could go through that into and equilibrate the pressure between the anterior chamber and the posterior chamber. And so this right here is called a laser peripheral iridotomy. Glaucoma is undergoing a revolution in its surgical techniques right now. There's a whole series of surgeries that have come out in the last 10 or 15 years that are collectively called micro-invasive glaucoma surgeries, or MIGS. And these include lasers and stents and catheters that can be used to flush out Schlemm's canal. And I'll show you a couple of examples of those down the road. But if you're interested in development of surgical techniques, this is a particular area of medicine that is just exploding at the moment. This, though, is an example, a schematic of the traditional glaucoma surgery, a tried and true procedure called trabeculectomy. This has been around since the 1970s. This is done with forceps and scissors, and you basically create an incision to pull the conjunctiva back. And then within the sclera, you create a partial thickness flap. And in the bed of that flap, you punch a hole through the wall of the eye. So now you've created a full thickness hole so aqueous humor can just leave the eye. And if you left things like that, the eye would shrivel up like a raisin. So we put that flap back and then we tie it down with sutures. And the key is you want to tie it down kind of tight, but not too tight, so that a small amount of fluid just kind of percolates out through this flap and leaves the patient with a pressure of about 10 millimeters of mercury. So it's a little bit of an art as much as it is a science. But this is the most effective glaucoma surgery to date, even despite all of those MIGS procedures. This is what this looks like as a schematic from the side. Again, this is the natural flow of aqueous humor in a normal eye. And this, when we've created this flap with a trabeculectomy, you have this new drain so that fluid can be drained into a blister or a bleb of conjunctiva underneath the surface of the eye. This is just a picture of a nice looking trabeculectomy. This area here is where the bleb is, and underneath here is aqueous humor that's left the eye and is sitting in this reservoir where it's being slowly reabsorbed into the bloodstream. Now, this doesn't always work so well. We're battling against the eye's natural wound healing response. You've just poked a hole in the eye and the eyeball knows that. And evolutionarily, it thinks that's a bad thing and tries to scar the hole closed. So this is a trabeculectomy that has scarred up and is no longer functioning because the eye is trying to heal itself. So several years ago, clinicians figured out that we can use antifibrotic agents, things like mitomycin, to poison the fibroblasts and prevent them from scarring the trabeculectomy. And that, on the one hand, has led to a significant improvement in the success rates of these surgeries, but it's also led to trabeculectomies that look like this, very cystic and thin and friable. And these things, unfortunately, can get broken down and leak and get infected. So as a glaucoma specialist, we're constantly doing surgeries to get people's pressure down so they don't go permanently blind from glaucoma, and then managing the occasional complications that occur as a result of those surgeries. Some other things that we do, if we don't want to make a drain out of the wall of the patient's eye, we can implant a plastic drain. This is a tube shunt that gets sewn to the sclera of the eye, and then it's connected to a plastic tube that we tunnel through the sclera, and the tip sits in the anterior chamber and will drain fluid to the subconjunctival space in between the eye muscles here. And this is what it looks like. It's all covered up by the conjunctiva. And then you can see the plastic tube sits in the anterior chamber where it can drain fluid from the back of the eye. Some of the newer procedures we have, this is called a Zen gel stent. This is sort of the same concept as a tube shunt, but it's much, much smaller and doesn't have a reservoir connected to it. But part of it sits inside the eyeball itself, and part of it sits outside the eye as well. And I can show you a video of how we implant these things. So we've just created an incision in the conjunctiva up here, and now we're looking at bare sclera. We insert a needle that has the Zen loaded into it. That needle goes through the sclera into the anterior chamber, and then the device deploys the stent as you pull the needle out. And it's so small that it's sort of difficult to appreciate in this picture, but there's this tiny little yellow straw sticking out of the sclera here and draining fluid. And we're tucking that down underneath the conjunctiva here. And then in a second, we're going to just put some of that mitomycin to prevent too much scar formation. And then we just stitch up this hole, and the patient walks away with a bleb and a new drain to let fluid out of the eye. So this is how we stitch it up. The stitches that we use in ophthalmology, this is a 10-0 nylon. This is significantly thinner than an eyelash or a human hair. So as you can see here, we use instruments to hold and maneuver the needle, and then we tie the knots with instruments, because you really can't tie this with your hands as you would if you were, suturing an abdomen or something like that in surgery clerkship. Another cool thing that we do is called endocyclophotocoagulation. So you guys may be familiar with laparoscopic surgery, where you have a device with a camera on it, and you can stick it into somebody's abdomen and operate in the abdomen without actually creating an incision, because you're looking at a TV screen that has a camera on it. Well, we have a similar thing in ophthalmology where there's a camera inside this tiny little probe. We can stick that into the eye and then visualize the internal anatomy of the eye. And this probe actually has a laser on it. So you can laser the ciliary processes and slow down how fast the eyeball is creating aqueous humor to keep itself inflated. So going back to the bathtub analogy, you can either unclog the drain, put in a new drain, or you can turn off the faucet. And that's what we're doing here. So now you see the view through the endoscope. We're inserting this into the eye. The iris is up here. And in just a second, we're going to go right behind the iris. And now we're actually looking at the ciliary processes of the eyeball. The lens is down here below. And if you look really carefully, you can see these vertical sort of spider web-like fibers. Those are the zonules that connect the ciliary processes to the lens and hold the lens in place. And you can see here that as we apply laser energy, these ciliary processes turn white and they shrink. We're basically just photocoagulating them so that they stop working and stop making so much aqueous humor that's driving the pressure up. This is one of my favorite procedures right now. This is the Hydrus trabecular meshwork bypass stent. As I told you before, sometimes the pressure is high because the trabecular meshwork is like a clogged drain. So if we can just put a stent through it and scaffold Schlemm's canal, which lies behind the trabecular meshwork, scaffold that canal open, then we can bypass that drain that's all clogged up. So this is an example of how this is done. We make a little incision in the cornea. We fill the eye with a gel so that the space is maintained and the eye doesn't collapse as we put instruments in the eye. Here, again, we're doing gonioscopy so that we can actually visualize the trabecular meshwork. And this is the device. It's loaded in an inserter. Once we get this in focused here, we're going to put the inserter, we're going to drive that through the trabecular meshwork. And then we put this stent all the way through Schlemm's canal. And it has a little snorkel right here that resides in the anterior chamber. So now fluid can go in that snorkel and access Schlemm's canal to be drained from the eye. So lots of different ways to lower the pressure, but at the end of the day, we're just eye plumbers. All right, going to move on now to a little bit about research. So I mentioned previously that I spend all my days in clinic and the operating room lowering eye pressure so that we can save people's vision, but we can't do anything to bring it back. So the focus of my neuroscience lab is actually to figure out how we're going to actually restore vision one day for people that have lost it in diseases like glaucoma and other optic neuropathies. And in order to do that, we're going to have to be able to replace retinoganglion cells with transplanted stem cell derived neurons. So this is just a schematic that kind of shows you what the ganglion cells do. They have to make it into the retina. They receive information through dendritic connections from bipolar cells and amacrine cells, and then they communicate that information via the optic nerve that goes all the way to the brain. And in order to restore vision in glaucoma, we're going to have to actually not just transplant retinoganglion cells, but get them to reestablish all of these connections within the visual pathway. So it's kind of a tall order. It's something that, you know, even with collaboration among many labs, is going to take many years. But we're working on it, and we've made some significant strides in the past few years. This is an example of some of the tools that we use. We have human-induced pluripotent stem cell lines that have special reporters that have been created with CRISPR-Cas9 engineering, so that when we create and differentiate our retinoganglion cells from the stem cells, they begin to glow red, as shown here. And so we can create hundreds of millions of retinoganglion cells in a dish in about a month. And then we transplant them into the eye. And when we first started doing this, I'll show you what happened. Right here, the human RGCs are in red, and they've been transplanted onto a mouse retina, which is intermittently shown in blue below. And you can see that these human RGCs grow processes on the surface of the retina, but they do not send processes down into the tissue. So there's really no way that they can form synapses with the bipolar cells or receive any information from the host retina in order to communicate that to the brain. So we've been hypothesizing what could be the barriers to the engraftment of RGCs after we transplant them into the eye. This is an example of some of the more recent transplants that we've done. And it's amazing that these things actually grow axons that go directly towards the optic nerve. Part of our work has identified that the internal limiting membrane of the retina it's a basement membrane that lies on the most superficial surface of the retina and separates the retina from the vitreous cavity. And that in and of itself is sort of a barrier to RGCs migrating down into the retinal parenchyma. So we've developed a couple of different methods to disrupt or permeabilize the ILM. And when we do that, these are the sorts of results that we get here. So again, you're looking at red retinal ganglion cells that have been transplanted into a mouse eye. These are the cells here. There's one cell that's engrafted into the retina. We've traced it so that you could see it a little bit better. And now we're going to put all the layers back together and show it to you in 3D. And the cool thing is you can see now that this retinal ganglion cell has dendrites that are beneath the retinal ganglion cell layer, and they're in this layer that doesn't have any nuclei in it. That's called the inner plexiform layer. And that's where bipolar cells and amacrine cells are going to give input about light signals to this retinal ganglion cell so that it can then go on and communicate that information to the brain. How do we know if a retinal ganglion cell is actually connected? Well, we have cool tools like this. This is called optical electrophysiology, where we knock in genes that where the fluorescence of the cell is directly proportional to the amount of intracellular calcium in that cell at any given time. And because when neurons fire a bunch of action potentials, it opens up voltage-gated calcium channels, and the intracellular calcium level goes up. So when you see a transient flux of calcium into a neuron, that's indicative of the fact that it's firing action potentials and becoming electrophysiologically active. So we've knocked that gene into some retinal ganglion cells here, and you see at about 10 seconds, they all get very bright. And that's because at about 9.9 seconds, we flashed light at the photoreceptors that were underneath these cells. So those photoreceptors detected the light, transmitted it into an electrochemical signal, passed that on to bipolar cells, and then the bipolar cells passed that on to the ganglion cells, and the ganglion cells started firing action potentials. So this is how we can actually look at the connectivity of neural cells in the retina in real time under the microscope. It's pretty cool stuff. I want to end with this, this observation that the ILM is a barrier to the engraftment of transplanted cells. How are we going to get around that? Well, one potential way is to, not that I want to turn you guys onto retina too much as a subspecialty, but I think that would have been my second favorite choice behind glaucoma. This is a surgical video from one of our retina specialists, Jim Handa. And this is a human patient. He's doing a vitrectomy. And what you're looking at here is a view of the patient's retina and optic nerve through the cornea using special lenses in the operating room. And after he's removed the vitreous, he stained the internal limiting membrane. And now he's using itty bitty, teeny tiny forceps to very gently peel the inner limiting membrane off the surface of the retina. This is something that we do now to treat diseases like vitreomacular traction and macular hole. And this may be something that is necessary for retinal ganglion cell transplantation in the future. The last slide about research here is I want to make a plug. If anyone out there is interested in basic science and neuroscience in the idea of vision restoration and optic neuropathies, we have an international consortium that now has over 250 members worldwide. And it ranges from very senior Nobel Prize winners that are interested in this kind of work to undergraduate students that are working on something like this in the lab. So if this is something that's interesting to you, either clinically or scientifically, please, you can either take out your phone and scan the QR code here to learn more about it, or go to the website. We have a better website, better URL now. It's just restore.info. All right, and then I wanted to end here with a couple of slides talking about vision screening, because this is something that you guys can do now to make a really important impact in your communities, but it's also something that you can continue for your entire career. And I think in our speaking with medical students at Hopkins who have participated in this program, that's been one of the key things that has been demonstrated to them, is that a lot of these volunteer efforts are not just, for students and trainees, but a way to make meaningful contributions for the rest of your life. So the Vision program was started at Hopkins in 2011. I was actually a medical student at the time. And as Christina alluded to, we had a general medical walk-in clinic that we would, take blood pressure, blood glucose, lipids, weigh people, and do BMI. But we did a survey and said, what are the most important needs that you have that you don't have access to right now? And number one was ophthalmology or eye care, and number two was dentistry. And I don't know that we figured out the dentistry thing, but we started the Vision program based on the need to deliver eye care to people that don't have it. And I just want to give you the three general tenets for how we developed this program to operate in what I think is an impactful and responsible manner. So the first thing is we don't just go out into the community and identify eye disease, but we do something about it. So whenever we find anyone that has abnormal findings on their screening exam, they're given a follow-up appointment at the Wilmer Eye Institute. And we used to do this purely by having faculty donate their time and see these patients for free, one at a time. We've now gone to having follow-up clinics that are staffed by an ophthalmologist, but also get the medical students involved so that there's continuity between the students that screen the patients and the patients see the same people when they come up for their follow-up care. The second thing is we don't just go out in isolation and set up shop on a street corner or in a mall and ask people to come get screened, but we actually partner with local grassroots community organizations, because these groups already have longstanding relationships with the people that they serve in the community. And so we partner with them because they know the people that need the help the most, and they can often provide resources like transportation and reminders and things to help them ensure that they get the follow-up care that they need. And then lastly, this has been and will continue to be a medical student driven program. There's faculty that help out. I'm the primary mentor, and we have about a dozen faculty that volunteer their time for screenings. But this is led by about 12 really dedicated executive board member medical students per year. And it's really the students program. They've done a phenomenal job with it over the years, and they continue to do great work. I want to give you a quick plug for yet another survey, because I've got the attention of many students right now. Johns Hopkins is not leading, but is part of a thing called the Consortium of Student-Led Eye Clinics. And this is a group of medical students at universities throughout the nation that participate in either student-led vision screenings or free eye clinics. And this group got together to try to help each other out, to have discussions about best practices, to brainstorm ways that we can all be doing this work better. And part of that involves trying to do a survey to better understand what are the groups out there at all the different medical schools throughout the country that are doing this kind of work, and what is everyone doing? What are they testing? What kind of equipment do they have? What do they do for follow-up? So if anyone out there is listening and does do any work at your home institutions in either vision screening or a free eye clinic, if you wouldn't mind filling out this survey, we'd really appreciate it. It's probably like a 5 or 10 minute thing to fill it out. All right, 40 minutes. That's what Christina told me was my absolute max before the cane comes out and pulls me off the stage. So thank you very much for your attention. And I think we have at least 20 minutes to answer questions and talk.
Absolutely. Well, thank you so much, Dr. Johnson. That was truly incredible. You fit so much into that time. So
yeah, my mouth is dry. I'm tired.
All right. So we would want to open it up for questions now. If anybody would like to come on camera and just vocally say your question. I know there was one in the chat too that we'll definitely get to. I would say the raise hand function, I think if you go to reactions, there can be helpful, and we'll be able to know you have a question that way.
Cool. So I see one in the chat. I'll just do the newly grown axons affect the passage of light to the photoreceptors? Good question. I mean, we haven't really tested that directly, but the old retinal ganglion cell axons that have died in the patients with glaucoma were in the exact same location and have the exact same structure and configuration as the ones that we're intending to replace. So ideally, if the new retinal ganglion cells are mirror images of the ones that had died, then they shouldn't affect the passage of light any differently than the retinal ganglion cells that the patient was born with did. But you never know what's going to happen when you start messing with biological systems and replace neurons with stem cell derived cells that weren't there to begin with. So it's a thing we'll have to test for.
Thank you. I'd had one more question specifically regarding the clinic that you help run. Are the screening exams performed entirely by med students, or are the ophthalmologists actually performing those exams as well?
So the maneuvers, the tests themselves are performed by the medical students. We have one faculty ophthalmologist that volunteers to be on site to kind of oversee the screenings and be there if there's a strange finding or the students have questions about something. But really each of the we divide it up into stations. So we've got a visual acuity station, an IOP station, FDT perimetry, so like an automated visual field station, fundus photography, OCT, pupils, and direct ophthalmoscopy. And each one or two medical students will be assigned to a station and do that one thing for the entire Saturday, and see every patient that comes through with that testing modality. And the patient will go from student to student. And then at the end, they'll have somebody summarize their findings and let them know what the recommendations are for follow-up. And the faculty is there to answer questions if needed.
I have a question as well about the clinic, because I think this is something that, at least at my institution, we run into a lot of issues with as far as starting a eye vision clinic. Is the amazing part about ophthalmology is all the technology and all the gizmos and gadgets galore, like you mentioned, but they also come at a cost. So how are you able to provide this? I guess going back to 2011 when the clinic started, how are you able to start this clinic when the cost of the devices that you use to screen are so expensive?
That's right. That's a really important question. And the first thing I will say is, if this is something that you're interested in or struggling with or need advice about, that's exactly what that consortium was made for. So even if you don't actually have a program up and running yet, if you just want help or advice or networking on how to get a program up and running, then join the consortium, because that's exactly, we have monthly meetings where we're trying to create like best practices and ideas for how to procure equipment and how to do various things. So I think that might be helpful to you. But to answer your question directly, you need funding. And when we started the program, there was a funding mechanism that was paid for by an entity called the Friends of the National Glaucoma Caucus, which was a congressional delegation that fundraised for the purposes of glaucoma screening. And they actually had a program that was specifically designed for medical schools, where they would buy $10,000 worth of equipment. And so that was an eye care tonometer, a visual acuity analyzer, and a panoptic ophthalmoscope, and an FDT perimeter. And then they would also give you $10,000 cash to set up the program and then do vision screenings. And I think everyone that was under that umbrella called themselves the Student Sight Savers Program. So that's how we started. We got one of those grants. My understanding is that several years ago, that program stopped existing. So I don't think you can go to them anymore, unfortunately. And that's partly why we don't have that name anymore. Now we're the Vision program instead of Student Sight Savers. But there are lots of other community organizations and foundations that will provide funding for this kind of thing. And part of what we're aiming to do on this consortium is look for national organizations that will fund. But I would also say, look, ask your university and look online at, the city that your institution is in. So in Baltimore, for instance, there's a handful of organizations like and some of these may be national, but the Weinberg Foundation and the Able Foundation, and they, have millions of dollars, and they have a website and grant mechanisms where they say, if you're a community service organization and you're doing good work in Baltimore City, then we have grants of $5,000 or $10,000 or $20,000. You just have to write the grant and apply. So for instance, we just got an OCT machine because the students wrote a grant that was funded by the Able Foundation. And so that gave us the money to buy an OCT. So it takes some work because you gotta go out and write the grants, and not every one of them is going to get funded. But quite frankly, it's good practice anyway, because in science and in medicine and in community service, grant writing is an important skill to have.
Thank you so much.
Does anybody else have a question that they'd want to come off? Otherwise, Jason, I can read your question. All right. How does the elevated IOP cause the retinal ganglion cell axon damage? Is it a mechanical mechanism or something else?
Oh man, that's $1 million question. People have spent 50 years trying to answer that, and we still don't really understand it. There's a couple of hypotheses. So if you think of the structure of the eyeball, and the ganglion cells are lining the back wall of the eye, they're sitting in the retina, and then their axons go on the surface of the eye until they get to the optic nerve, and then they make a 90-degree turn to go out the back of the eyeball into the brain. And so when the eyeball has a change in pressure, the eyeball is not a rigid structure, it's an elastic structure. And so just like if you blow up a balloon, the balloon gets bigger. If you raise the pressure in an eyeball, it doesn't necessarily get significantly bigger, but it definitely causes stress and strain and bending and movement within the sclera and the structure that supports the optic nerve itself, called the lamina cribrosa. And so one theory is that when the pressure goes up, then you have either a kink in the axons, or you have a smushing of the axons between beams of the lamina cribrosa, or some sort of a biomechanical deformation that causes either mechanical trauma to the axons or a metabolic or molecular defect. It's been shown, for instance, that retinal ganglion cells are constantly producing proteins of all sorts in the cell body, and those proteins need to be transported to the axon. For instance, if you want to make neurotransmitter that is going to be released in the lateral geniculate nucleus of the brain, some of that may be able to be translated locally in the axon, but a lot of it has to be transported down the axon. And so when the pressure goes up, there's a blockade of axonal transport that occurs exactly at the optic nerve head. And that may be partially pathologic as well. There's also a competing theory, though, that blood flow is really important. And obviously, blood flow is based on pressure. So if the pressure in the eyeball goes up, that's providing back pressure against the perfusion of blood and oxygen and nutrients coming from the blood vessels that are entering the eye. So, it's probably not one or the other. It's probably that a lot of things are important, and they may have different relative importance in individual patients. But short answer is it's not an easy question to answer, because we really don't know.
Thank you, Dr. Hudson. I then please feel free to use the raise hand function if there are any kind of more live questions, but I then want to go from some that were pre-submitted. And so could I ask you, what is the most rewarding part of your job, Dr. Johnson?
Oh man, I don't know. It's so hard because I get to do so many things, and I think each of them is rewarding in their own right, and when I'm there, so like when I'm in clinic, I see patients on Fridays. I have one clinic day a week. And when I have just done a surgery on a patient and they take the eye patch off and say, oh my God, I couldn't see anything, and now my vision's so good because I took a really bad cataract out or something, like that's amazing. And as a glaucoma specialist, one of the things I love about the specialty, for better or for worse, it's not good for the patient, but glaucoma is a lifelong disease, right? And so when I have patients, these are my patients for life or until one of us moves away. And so I haven't been in practice that long, but I have patients that I've known for 5, 6, 7 years, and I know about their families, and they ask me about how my kids are doing. And, it's really nice developing these relationships with them. So when I'm in clinic, that's like the most gratifying part of what I do. But then when I'm in the lab, to think that what we're doing now could potentially create a therapy that would actually, what we're aiming to do is to cure blindness, to be able to reverse vision loss from a disease that's currently leads to permanent blindness. And, we're not there yet, but when we make major headway, when experiments work and we feel like we're really down that avenue, and it's going to be something that may come to fruition, that's incredibly rewarding because that has the potential to impact millions of people throughout the world. And then when I'm interacting with students, being able to teach is also amazing. To see that there's 67 people on this call at 8:00 on a Wednesday night is awesome. And you guys are the future of the field. And so just to be able to kind of talk to you guys and get you excited about the things that we do, I think that's awesome.
Thank you so much. And Hassam, did you have a question?
Yeah. Hi, Dr. Johnson. Thank you for the great talk. Just a quick question regarding, again, on the same note, the vision screening and the student-run clinics. I think those are wonderful, but like at an institution, for example, where we just don't have the support or, the resources to have a student-run eye clinic, for example. And we do have the ability to do community screenings, but obviously, as you mentioned, one of the biggest issues is the lack of follow-up and the lack of, after we screen them, okay, great, now what? Referring them is one thing, but ensuring that they get that treatment, care and treatment is another. So do you have any recommendations for any advice on that route, but also just in general, for example, dry eye? One of the initiatives we've started is distributing, artificial tears and eyelid wipes and warm compresses. Do you have any other those types of conditions that you think would be tangible to treat on site?
It's tough. It sort of depends on your screening, because the main concern I would have is I'd want to be 100% sure that whatever was being diagnosed was accurate. You'd hate to give somebody artificial tears for dry eye only to find out that they actually had herpetic keratitis or something like that. But if we assume that the ability to screen and diagnose people accurately is there. There are groups that are able to do glasses on site, or you can either, there are ways now with relatively small footprint equipment to make glasses like in a van, but easier than that is there are glasses drives and things like Lions Eye Institute and things will have people give their old glasses. And if you have the means to at least measure them and know what they are and then refract people, you can kind of match people up to the right kind of glasses. Beyond that, there aren't many eye conditions that are amenable to over-the-counter treatments is the problem. You need a doctor to be writing prescriptions for things if they're needed, and usually it requires fairly sophisticated diagnostic machinery.
Right.
So,
All right.
I think-
Well, yeah, thank you. Just want to confirm my suspicion, I guess, because that's pretty predictable, but good. Thank you so much.
yeah, where are you coming from though? Because I mean, the other key is even if your institute doesn't have a very large ophthalmology or any ophthalmology department, sometimes there's other programs in the city or, somewhere somewhat nearby that you could partner with or, volunteer with or something else. So that may be another possibility.
No,